Good morning, everybody, and I also would like to say happy National Athletic Training Month. We appreciate all of our athletic trainers here at the hospital, as well as all of those out in the community, and for everything that you guys have done and continue to do for athletes, but especially our youth athletes. So we appreciate you guys. So today we're going to talk a little bit about acute ankle injuries. I unfortunately don't have anything to disclose. So our objectives, we're going to discuss commonly encountered acute ankle injuries in a young athlete. We're going to discuss considerations for safe return to play following an ankle injury, and talk about prevention and rehabilitation following an ankle injury. We all know ankle injuries are common. We see them a lot, especially in young athletes. Ankle sprains are 16% of all injuries and amongst young athletes. In the emergency department, ankle injuries represent between a quarter and half of all sports-related injuries presenting to the emergency department. Ankle injuries account for 1 in 4 of recurrent injuries among high school athletes. So you have it once, you may have more of them. And in some sports, girls tend to have a higher rate, such as soccer, softball, baseball, or track and field. But in sports like basketball, volleyball, and lacrosse, the rates are similar. So it's an issue that impacts both sexes. We tend to see more injuries in dynamic sports, jumping and cutting type sports with basketball, gymnastics, volleyball, soccer, football, accounting for the majority of acute ankle injuries. So think about any sort of indoor court sport or sports that involve player-to-player contact are a little bit higher risk as versus maybe an outdoor sport or outdoor court that doesn't involve contact. Repetitive activities tend to have a little bit more overuse injuries than some of the acute injuries that we have. So cross country and soccer also will have acute and overuse injuries. So when we're seeing a patient, any athlete with an injury, whether it's ankle or otherwise, it's really helpful to get a good history. In our setting, we tend to work with a lot of medical students, residents, fellows. I think that when they come and provide a good history to us after evaluating the patient, we often have a really pretty good idea of what's going on with the patient. And so I think that tells us the importance of a good history before our exam to kind of have a good idea of what our differential is and what maybe is going on. And so we'll talk through some of these as we go through the talk, but age, especially in our youth athletes, there's going to be a big difference, and we'll talk about that as we progress. But the sex of the athlete, what sport do they play? What position do they play? What level of competition? Is this a recreational? Is this a club sport? Is this a school sport? Where are we in terms of the season? Is this preseason? Is this playoffs? Is this right in the middle of the season or the first game? What are their long-term goals, and what do they have going on after this? Is this senior year and we're looking at playing at the next level, or is this somebody who really doesn't have much desire to continue playing after this and we have only 1 or 2 games to get them back? And have they had any previous injuries? Maybe the same ankle, previous ankle injury. Opposite side, knee injuries. Did they recently have a concussion? We know that there's an increased risk of musculoskeletal injuries after a concussion, and so that's something else to think about as well now. When they present, is this an acute or chronic issue? A lot of times, depending on your setting, you may be evaluating these in the acute injury setting, and we're talking really about acute injuries today. But a lot of times, actually, acute injuries will present to us in a chronic fashion, meaning that they injured it months ago, and they're finally presenting to us with an injury that wasn't adequately evaluated or rehabilitated, and we're dealing with still that acute injury and the effects of that, or the sequelae of that. What was the mechanism of the injury? For those of us that may be on the sidelines, especially athletic trainers and such, so if you see it happen, that's really helpful, but a lot of times we don't. I'm surprised at how many facilities now have videos. Whether you have kids that may play club sports, there's a lot of money to be made in youth sports. So now you can sign up for these subscription services that have, videos. So there's almost always somebody's camera that's going, whether it's a parent who's videoing or it's these things, that are in the facilities. So oftentimes the parents will pull out and say, hey, do you want to see it? You want to see what happened? I say, great, yeah. And so you're able to see exactly what happened. I think that's helpful for us to try to determine which structures may be involved and maybe what happened, if we can kind of reenact or understand. And if not, having the athlete maybe demonstrate. And a lot of times I'll tell them to demonstrate on their good ankle, the one that's not hurt. Say, kind of show me what happened exactly. Because if they say, I rolled my ankle, well, what does that mean to you? Show me kind of what happened and through there. Did it swell up? Did you hear or feel a pop? Were you able to put any weight on it afterwards? Were you able to keep playing? Somebody that was able to keep playing, didn't have much swelling, was a little bit sore, maybe a little less concerned than somebody who immediately couldn't put weight on it and had to come out of the game. Where's the location of the pain? One thing that I find really helpful is asking the patient to point with one finger to one spot. And I say, you get one finger, one spot, point. Where does it hurt? And if they can't do that, that's also helpful. But a lot of times they'll put their finger on the structure that may have been injured or damaged, and that's helpful to kind of guide us in on what landmark that is. And then what have they already tried? We go through a lot of times of what have you done so far, so we're not just making the same recommendations. And also, have you had kind of the right treatment up to this point through here? So we'll go through a few cases today. Our first case is going to be a 17-year-old female who comes in, she rolled her ankle at soccer practice just a little bit ago. She's hurting fairly badly and can't put any weight on it at this point. There's quite a bit of swelling around her ankle. So fairly common scenario, whether you're in the training room or you're in the clinic or maybe in the PT setting. But so these are some of the questions that, I kind of think through. What's probably going on? 17-year-old kid rolled their ankle, it's swollen. What's the most likely diagnosis, and how do you typically sustain that type of injury? When do we need to get imaging on these? And if we're going to get imaging, what are we going to order? And what does our initial treatment entail? What are we going to kind of do early on in the acute setting for these types of injuries? And when do we need to refer these on, perhaps, to have a little bit further evaluation? So just kind of a brief review of some of the anatomy and motions here. So this first, in A, we're looking at the ankle from the lateral side here. So here's your fifth metatarsal coming down towards your little toe here. And we have our lateral ankle ligaments. So we have our growth plates, the physeal in through here, and our lateral ankle ligaments. Here is your ATFL, your anterior talofibular ligament, attaching from the fibula to the talus there. You have your CFL, or your calcaneofibular ligament, coming down to the calcaneus, and your PTFL, your posterior talofibular ligament, attaching from the posterior aspect of the lateral malleolus back into the talus and through there. And then we come over onto the medial side of the ankle, and we have this more broad-shaped triangular ligament complex, which we refer to as the deltoid ligament. And as you can see, just by visually looking at that deltoid ligament versus these kind of three more scrawny ligaments on the lateral side, the deltoid ligament's a little bit more robust and a little bit less frequently injured. These are kind of the motions when we often think about when we say rolled. When you say, oh, I rolled it in, what does that mean? And so we use the words inversion, which is the more common mechanism, versus an eversion, where you kind of roll it. And so again, in and out are sort of hard if somebody tells me I rolled their ankle in or out, so we tend to say, inversion injury or eversion type mechanism there. So with most ankle injuries, and so with that patient, that 17-year-old female, swollen ankle, most likely going to be an ankle sprain. Very, very common injury. We see lots of these. And the majority of these are going to be inversion type injuries. Sometimes there's an inversion and eversion. They kind of compensate and roll back the other way so they can get both the lateral and the medial side. And it's less common to have just an isolated medial ankle injury. And so we're looking at that mechanism. Again, the inversion, injured tend to be the outside, the lateral ligaments of the ankle there, with the ATFL, or the anterior talofibular ligament, being the most commonly injured ligament in these sprains. And then we know, just semantics-wise, I think this is a term that people throw around, sprain and strain. I very commonly will see patients that have been seen in the emergency room, and the terms sprain and strain kind of maybe get misused. A sprain with a P tends to involve a ligamentous structure. It's typically a stretching of that structure beyond its limits with an injury to the ligament, versus a strain with a T tends to involve a muscle or a tendon type injury there. And so just using those, so we're talking about a sprain, so we're specifically referring to a ligament injury. And so I think the general public, sometimes they get very concerned because they come in and they, we'll talk in a minute about imaging, but very commonly will come in with a report maybe that they've found out that their child has torn ligaments in their ankle, and they're very concerned about this. And then when you sort of try to explain to them, well, that's what a sprain is, right? A sprain is a ligament injury, but when we call it a sprain, like, oh, you just sprained your ankle, but we say, oh, you tore ligaments in your ankle. Now all of a sudden it sounds significantly worse, but it's really the same concept that we're talking about in through there. So I think keeping that in mind as we work through some of these, and understanding that, again, very, very common injury, and this is different than perhaps tearing a ligament in your knee, such as the ACL. very different injury that we're dealing with when you tear your ATFL. They sound a lot alike, and they're both ligament sprains, and you could tear both completely, but we're going to manage those quite differently, and because the complications, the morbidity, the problems down the road are significantly less with ATFL injuries or ankle sprains. One of the challenges that they will have is they can have recurrent injuries, chronic instability, but we can deal with that. We can deal with that down the road, but a lot of people go on and do just great. So we sometimes will grade these, grade 1, grade 2, grade 3. It's a little challenging, and we will sometimes do this, but I think it's sometimes helpful prognostically, just really to let everybody know that not every ankle sprain is the same. And we're not going to get every athlete back the same, because somebody may come in with a very significantly injured ankle that's very swollen, not able to bear weight on it, and it's an ankle sprain. But somebody else may have barely tweaked it, and they're back playing 3 or 4 days later and feeling pretty good. Still an ankle sprain, very different injury. Maybe the degree of involvement of the ligaments, maybe the number of ligaments injured is much less. And so when an athlete's, well, why are you telling me that it's going to take me this long to get back when my teammate was able to get back, for the next week? Why, we both had an ankle sprain. What's the difference? So I think sometimes it's helpful for the coach, sometimes it's helpful for the team and the athlete and the family themselves to just understand that this is a worse injury. It's going to take a little longer. So it's not as much about the number as it is just understanding the severity of the injury. But grade 1s, typically there's not much swelling, maybe a little bit of bruising, not much. They can usually walk on it, bear weight, and you can usually get them back pretty quick. And again, a lot of times when I think about these ligament injuries, sometimes I'll show families, hey, a ligament's like a rope. And so a grade 1 may be just a very partial injury. Maybe a grade 2 is kind of stretched a little bit and a partial tear, and then grade 3 may be a complete tear there. So we understand when that rope or that ligament gets stretched, there's different degrees of damage. And so if you just barely do that and it's a grade 1, well, that's going to heal back much more quickly. It's going to heal up tight, not have nearly as much bleeding, pain, swelling, and problems down the road. A grade 2, now you see a little bit more swelling there, maybe more bruising. They can limp on it, maybe walk a little bit, probably not ready to run on this, takes a little bit longer. And then a grade 3, again, oftentimes you lose your bony landmarks, you can't see the malleoli. That's the really swollen one. They have this kind of, their toes are swollen, and these take a while. These take a while to get back usually. These are the ones that, even if there's negative x-rays, they're pretty sore. They can't put any weight on it. You're hard to examine. They don't have a whole lot of motion early on. So imaging, we'll talk a little bit in a minute about some decision rules to help us guide on this. But I think the central concept is if we're worried that there's more than a sprain going on, if there's specific bony tenderness, point tenderness over the bone, if they're not able to put any weight on it, if it's a really swollen or ankle that looks like that one we just saw in through there. In our standard views, we typically get 3 views. We get the AP and the lateral, which are common, and then we get what's called the mortise view, and I'll show you a picture of that in a second. But the mortise view is a third one that I want to make sure that we're including. A lot of times people say, oh, ankle series, and they just get maybe 2 views, or they get some random oblique type view. But the mortise view, I think, is helpful and provides some extra information. MRIs are not something that we commonly order for acute ankle sprains. We will order them in other areas if we are concerned that there's a different type of a fracture pattern, or perhaps what we call an osteochondral fracture. We're looking for a cartilage type injury, maybe if we're looking for something along those lines. But I think that, again, if you get an MRI on an ankle sprain, you're going to get a pretty long MRI report with multiple ligaments involved and partial tear and complete tear. And again, then you're going to end up having an athlete and a family and a coach that's pretty worried because they've got multiple torn ligaments in their ankle. And so we often spend quite a bit of time having to kind of talk an athlete down and explain to them why this doesn't need surgery, and how we are fairly confident that they're going to do quite well functionally and get back to playing their sport at a high level without surgery, despite how bad their MRI looks. And so if I end up getting an MRI, often we'll kind of give the family the heads up on that. We know this is a sprain. We expect to see ligament damage. That's what a sprain is. But we're doing this to look for cartilage injury, for example. And that's why we're getting the MRI. So here are our sort of standard x-rays. On the left, we have the AP view here, and you can see the physis. This is your lateral malleolus, the outer side in through here, and your distal fibula. And then here's your distal tibia and the physis, or the growth plate, coming in through there. And this is your talus in through there. So you can see on the AP view, sometimes you'll see some overlap. and may not be able to see this lateral margin of the talus in through there. So here is a mortise view where they slightly angle the ankle a little bit, and it really shows us, again, what we call the mortise of the ankle, which shows us that talus very nicely, and may show a slightly different angle through the distal tibia here as well. And then a good lateral view is also helpful. Some of the things that we'll look for in addition to just fractures in through here on the lateral view, sometimes we're looking at the pattern of the bones. If an athlete has what we call a tarsal coalition, which is perhaps where maybe, for example, if the ankle, the talus and the calcaneus, what we call the talocalcaneal coalition, if the bones are fused together, then they have less movement through that subtalar joint, or underneath here, they're not able to have normal movement patterns, which is going to predispose them to ankle instability and ankle sprains. And so we may look for that on our lateral view, and sometimes we'll see what we call the C sign. This is not one, but where we can't see a distinction between these two bones, and it looks like the letter C, or almost like a little Pac-Man on there. And so that's something else that we can see on X-rays and through there. So in general, this is one commonly used clinical decision rule. It's called the Ottawa ankle rules. It's been very well validated, and it has been validated in the pediatric population. So it is able to be used in the adult and the pediatric population. This is very, very sensitive, okay, which means that it's very good at picking up on any fractures that's there. It is not very specific, which means that most of the time you're getting X-rays following these rules, you are not going to see a fracture. So you're not going to miss many fractures by following this, but you're probably going to get a lot of X-rays that are normal or negative. So it's a good screening kind of rule, but there's been some other modifications to it that may be a little bit better specificity. But this is a very commonly used one. But essentially, what you're looking for is tenderness along the posterior aspect of the lateral malleolus or the medial malleolus. And the reason for that is the ATFL that we talked about attaches to the anterior portion of this lateral malleolus and to the talus and through here. And so when we have a sprain, the majority of the time that ATFL is going to be involved, and they're going to be tender over the ATFL ligament and the attachment on the anterior aspect of the lateral malleolus. So tenderness over the lateral malleolus and the anterior aspect is not necessarily indicative of a fracture, just as likely to be a ligamentous injury. But now if we move to the back, the posterior aspect there, then now you've moved beyond where that ATFL attachment is, and so there's either more significant injury with more ligamentous involvement or perhaps a fracture in through there. And we're also palpating around the physis up in this area. So if they can't bear weight at the time of the injury and in an emergency department or wherever your setting is, or they have significant bone tenderness over one of those spots, then we're going to get X-rays of their ankle. And again, I'd want to get those three views, the AP, the mortise, and the lateral view. Now, if they have a little bit of tenderness, we also push a little bit further down into the foot. We push over the base of the fifth metatarsal here, and we push over the navicular tubercle. If they have tenderness over either of those spots, we want to add a foot series and get foot X-rays in addition to the ankle X-rays, or instead of the ankle X-rays. But it's slightly different because the ankle X-rays don't visualize those, and you can have avulsion fractures of the navicular or the base of the fifth metatarsal from their tendon attachments there, in addition to the ankle injury. So when you're doing your exam, you want to make sure you palpate those bony landmarks in addition to the malleoli and come just a little bit further down into the foot there. All right, treatment. So it's obviously not a one-size-fits-all approach, as we already alluded to. There's a lot of differences in athletes and injuries themselves. And so, I'm sure everybody here has heard of RICE, right? Well, you may have heard of RICE, but have you heard of PRICE? But you may have heard of PRICE, but have you heard of PRICEMMS? Well, you may have heard of PRICEMMS, but have you heard of PRICEMMS? We keep adding letters because really, there's not really a great treatment that we say. There's a lot of evidence that this is the best way to treat ankle injuries. And so we kind of start doing lots of these things. And a lot of you I see in the audience, I know you treat a lot of these injuries. And you know how it is. And you guys are kind of throwing a lot of your tools at these things. But in general, concepts are similar across this. So we want to protect them from further injury. And sometimes that means we need to protect them from participating. Sometimes we need to protect them from walking around on it. And we'll talk a little bit about boots or casts or whatnot later on, but it's some sort of a brace or something to get them a little bit more comfortable and give them some support. Relative rest is a concept that I like as opposed to complete rest. Relative rest means we don't want to do things that make that particular area hurt. So if you have an ankle injury, you can still probably do some upper body weightlifting. You can probably do some core work. You can probably do some other things. And so, I think a lot of times, maybe not much in the sports medicine world, but some of our other healthcare colleagues that don't manage athletes very much, they just say, well, shut it down. We just write a letter, no activity. And so that's maybe not ideal for any of us, but certainly not our athletes. So what else can they do? And then ice, there's not a lot of evidence that ice is really going to speed up the healing process in these ankle injuries. Helps with pain, may help with swelling, and so it's certainly a very reasonable thing to do. It's a very commonly utilized modality, but despite the common use of, despite how common ankle injuries are, and despite how common it is for us to use icing, we don't have a lot of data that shows that it makes a big difference. Compression, I do think that this is something that helps again with some of the swelling, and same thing with elevation, trying to get that elevation, to get that swelling down. And some of that is we want to get them mobilized early. If they're really swollen and sore, then it's harder for them to get their movement. And the early mobilization is important. And so if we can get their swelling down, we might be able to get them moving a little bit more quickly. And sometimes the earlier you get them moving, the faster their swelling gets better. Medications as needed. I don't know that there's a lot of evidence that that's going to make them heal faster, but we can certainly treat their pain. But a lot of these other things that we're doing too will help make them comfortable. And some of our athletes, it's actually helpful for them to have that pain feedback. We don't want to just cover up their pain with a bunch of medicine, and then they keep doing things that may be aggravating the injury and not focusing on their healing and through there. Mobilization and strength, I think, are super important. If possible, we want to get them moving early on. Some of these more severe injuries that we're going to talk about, some of these fractures, and some of the more significant grade 3 ankle sprains, they just hurt so much that sometimes they'll benefit from a brief period of immobilization before we get them going. But even then, we can start to try to work a little bit on that. And so, simple home exercises, we really want to work on the dorsiflexion. If you look at the model here on the right, the anterior portion of the talus is it's wedge-shaped. So the anterior portion is a little bit wider than the back. So when they're down in plantar flexion with their toes sort of pointed down, then the back part of that talus is in the mortise there, and it's a little bit more narrow, and you have more inversion and eversion in the ankle. It's a little bit more unstable position. So a lot of these injuries that we see, be coming down from a layup, and they're sort of in a plantar flex position coming down to land on their toes, and then they roll over, they invert their ankle there. And so we really want to work on the dorsiflexion, getting them back. That's the more stable position for the ankle. So we work a lot on Achilles, just Achilles stretching, towel stretches, pull around, get them up moving. And the alphabets is a super common, very basic thing to start with. A lot of our patients, may not have access immediately to an athletic trainer or physical therapist or something. And so these are, whether you're in the emergency department or the pediatrics office or something, these are very simple things that you can do at home without any equipment and without any resources. Strength, we really want to work on the perineal muscles and try to help provide those stabilizers so that the next time when that ankle starts to roll in, that those perineals can kick in and correct that. And so that's where the proprioception is really important too. So we can start early on with some balance training and some high repetition, sort of low resistance strengthening exercises in through there as well. So this is just a very simple concept of, these are some things that can be done at home. And we'll talk a little bit about, at-home programs versus, guided rehab programs. There's not a lot of data that shows a huge difference if they're both done. I think that most of us treat adolescents and kids and know that if I give them a home exercise program and say, go do these exercises, but there's no accountability and there's nobody kind of helping make sure they get done correctly, there's a very big difference in what's going to be done versus if I send them to physical therapy or they're working with their athletic trainer and there's somebody that's helping and making sure they get done. And so I am personally a big believer in guided rehab programs, but these are some basic things that we can kind of get started on with them. So high ankle sprains are a little bit different than sort of the traditional lateral or medial ankle sprains. This comes up a little bit into the syndesmosis between the tibia and the fibula, and it also will involve oftentimes what we call the AI-TFL, or the anteroinferior tibiofibular ligament there. And this is a little bit more of an external rotation, so a lot of times they get kind of rolled up in a pile and their foot is externally rotated, or the ankle's externally rotated, and it sort of spreads apart. This talus in here wedges apart between the medial and lateral malleolus, and then it kind of comes up in this direction. So these are oftentimes more tender. So here's your ATFL over here than the AITFL. So a little bit more anterior type pain when you're pushing on them. Oftentimes they'll kind of come up. We can do our what we call syndesmosis squeeze, where we're squeezing together up and through here. And when we squeeze here, that makes this area here kind of spread apart a little bit, so it may cause pain down in that area. We can also do what we call our external rotation stress test, where we're intentionally externally rotating, again, trying to wedge open that to cause some pain in through there, in that region. On x-rays, we'll look for some widening of the mortise in through here. So where this arrow is showing, that's obviously a big gap that shouldn't be there. This patient also has a fracture through the distal fibula there, you can see as well. But this is an unstable ankle joint that's going to need to be fixed. And if these go unrecognized, then that patient's going to have significant problems trying to get back. And so this needs to be referred on for surgical intervention through there. And you can also see, again, a lot of swelling. So here's kind of the edge of the bone, and there's a lot of swelling in this ankle. Sometimes these come in and they're really, really swollen and hard to examine. All right, so return to play in general is a concept that a lot of us do very frequently. And so this is not unique just to ankle sprains, but I think these concepts that we're going to cover here are applicable in a lot of our situations. And in general, we need to have full range of motion, we need to feel better, have less pain, normal strength, psychological readiness, and the ability to demonstrate adequate sport-specific skills. So I think those are fairly basic, good concepts for return to play. But we can go a little deeper with it than that. And so there's kind of three different levels that you can sort of go. So one is the the medical side of it, kind of the injury itself. Two is sort of the actual risk of the participation, and then three are all the other things that kind of affect all of that. And I think that we, all of us tend to go through this concept fairly quickly, but with every one of our athletes. And this is why those things when I was talking about in the history are so important, because that's going to impact my plan, right, in my treatment for the patient and return to play. And we may be much more aggressive depending on their level of play, their timing of return, but we have to think about, is it safe for them to go back? When they go back, are they going to be able to perform and function at a high level? Are they going to significantly worsen their injury? Again, what are our goals? What do we have after this weekend, right? They always want to play. They want to play tonight. They want to play last night. They want to play this weekend. But maybe it's actually 2 weeks is the really important time that we need to get you back for. But if we don't have those conversations with the athlete, they're not going to think that far ahead necessarily. And so sometimes framing it back for them and letting them understand, we understand that you want to be out there this weekend, but really this is where we have to go on. Let's buy us 2 more weeks to allow for injury healing, rehabilitation, get you back out there. And then when we get you back out there, can we modify, can we decrease your risk by putting you in a brace? Can we decrease your risk by taping you? Those kinds of things to help provide a little bit more support, but again, really focusing on strength proprioception. The concept that I explain to the families, but a lot of times my residents is, if we wait long enough, the pain and the swelling will go away in general. But so if they sit around and do nothing and then they try to go right back to their sport, their risk of injury is super high. But their motion, their strength, and their balance, if we haven't adequately addressed those, then I think they're just going to have recurrent issues. And so those are one of the things that we tend to focus on. And again, whether it's physical therapy, working with their athletic trainer, guided home program, we want them doing some rehabilitation and through there. So in general, again, not much pain. They have to have a stable, relatively stable joint. Have to have a good motion, normal strength, relatively symmetric to the contralateral side, good balance and proprioception. Can they protect themselves from further injury? And if not, are they not able to maneuver and react? Then they may end up with, an ACL injury. They may end up with a concussion if they can't maneuver and get out of the way because their ankle is inhibiting them. We typically go through a functional progression and make sure that they can progress. Can they kind of maneuver in a straight line, and then can they build up, and then can they do full sprints and stops? Can they do lateral movements, cutting movements, jumping movements, and do that, and then get back into their sport-specific activities? We do want to rebuild their confidence, and then again, as we talked about, their risk of further injury. So when do we refer some of these ankle, I guess especially ankle sprains on? But I think if you are worried that there's a fracture there, whether that's your Ottawa ankle rules or just your kind of clinical judgment, or if you know there's a fracture there, I think those are good to refer on and have somebody help manage. If you're concerned about a high ankle sprain, if this is an athlete who has had recurrent ankle injuries, again, whether they weren't adequately rehabilitated the first time or there may be more going on in through there are certainly treatments that especially some of my partners can do in terms of surgery and things for those high-level athletes that continue to have instability. If this is maybe a higher-level athlete that needs to get back a little faster and may benefit from a more rapid return to sports, then a team approach, I think, is often very helpful. And some of this also, a lot of our pediatrician colleagues see a lot of these ankle sprains, and these are good ones to refer on as well. So, or if they're just not getting better, you're kind of treating them and something's not quite right, that's always a good reason to look into that. Maybe there is something else going on. Maybe there's, an underlying cartilaginous injury, or maybe there's something else in the athlete that they just, maybe, other factors going on. They don't want to get back to going to their sport, so we can kind of help evaluate those. So we'll move on to our next case. So now, our first one was a 17-year-old female. This is a 10-year-old male who presents, same story, rolled his ankle. His was a week ago. His was basketball. Still having a lot of pain, still not able to walk on it, and his ankle is swollen and bruised. So, same questions. What is the likely diagnosis? What's the mechanism? When do we need to get imaging? What does our treatment entail? When do we need to refer these on? So the difference between case 1 and case 2 is, I give you a 17-year-old in case 1, I give you a 10-year-old in case 2. They're not the same patient. And a lot of that has to do with skeletal maturity, growth plates, right? When we talk about kids, we say think about the growth plates first, whether that's an acute injury or whether it's an overuse injury, the growth plates are susceptible to injury. So just a review of sort of a normal kind of growing bone, the physis is the growth plate itself, okay? The diaphysis is the shaft coming down. The metaphysis is the area kind of adjacent to the physis, and this is where we add new bone. And then the epiphysis is the growth center on the end that attaches to the joint and through there with an E. An apophysis with an A is typically a site of bone or tendon attachment. So for example, in the pelvis, we have lots of apophyses, or on the front of our knee, our patellar tendon attaches to an apophysis on our tibia and through there. And so those also are susceptible to injuries, but the apophysis is slightly different than the physis and the epiphysis, which are adding length to a bone. Those tend to add shape or contour to a bone. Another review of sort of some concepts. In the pediatric world, we tend to use what's known as the Salter-Harris classification for fractures. And this helps us sort of classify a different fracture pattern involving the growth plate. And based on that will help us determine the risk of complications as well as our treatment algorithm. So on a type 1, it goes through the physis itself, and doesn't involve the metaphysis or the epiphysis. It comes in through here. You can see some of the periosteum is a little bit elevated, but this is a distal tibia Salter-Harris 1 fracture. A type 2 comes through the physis and up through the metaphysis here. A type 3 is coming through the physis and involves down into the epiphysis. A type 4 is going to involve the physis, the metaphysis, and the epiphysis. So it's sort of almost like a combination of a 2 and a 3. And then a 5 is a crush injury, which is a pretty uncommon injury, and we don't see a lot of those. So, I think that the higher number you get tends to be a little bit worse injury in terms of the risk of problems down the road. And some of that is when you look at the articular surface or the joint surface here in the type 1, and in the type 2, the fracture does not involve that joint surface. But a 3 and a 4, the fracture is coming down and involving the joint surface. So if this doesn't heal exactly anatomically and looking very nice, if it's not lined up or if there's space or there's a displacement in through there, then they're going to end up having more problems. And so the 1s and the 2s typically are managed, if they're not displaced a lot, typically managed without surgery. They tend to do fairly well. And those can be managed oftentimes non-operatively, but the 3s, the 4s, and certainly the 5s, I think those are ones that you'd probably want to phone a friend and have somebody help you if you're not comfortable managing a lot of these growth plate injuries and look at that. On the Salter-Harris 1 fracture, the distal fibula, we will talk a little bit about here, but so this is a patient, kind of says it hurts right in through here. Where does that line up on an x-ray? Well, there's that distal fibular physis in through there. So again, as we said, the 1s and the 2s don't involve the joint surface, typically do pretty well. 3s, 4s, and 5s, you need a specialist. So we want to think about Salter-Harris 1 fractures, okay, not just in the distal fibula, but anywhere. If we have tenderness over the growth plate, whether it's the wrist or whether it's the distal tibia, and think about those. But oftentimes the X-ray may be negative with the Salter-Harris 1, but we'll talk a little bit about these and some more literature that's kind of come out more recently as we move forward. We don't really typically get stress views on the growth plate unless it's done. Sometimes we'll do it here, but usually not. If they have a medial ankle sprain, again, that may be more likely to be a tibial Physeal fracture. These are a couple of things that have shown up on the pediatrics board several times, is that basically they want us to think about a fracture, potential fracture, anytime that a kid is limping, having pain, and younger kids with open growth plates, we got to think about a growth plate fracture instead of an ankle sprain. It's got to be in our differential, okay? So here's an X-ray showing on the right side, this patient's distal tibia. Their physis here is a little bit wider. This is their normal uninjured side on the left side, and through there, not as wide. So these are a little bit more at risk down the road. If you have a Salter-Harris 1 through your distal fibula, even if that growth plate doesn't do very well, the complications are pretty low. If this doesn't grow as much, this one's a little bit more significant. The tibia bears much more of the weight, so we're not quite as worried about these Salter-Harris 1 to the distal fibula maybe as we used to be. So this is a study. There's been several studies, so I chose to highlight some studies throughout this talk instead of trying to kind of cover all of them. But this was a study that was done back in 2016. They looked at 135 kids who were seen in an emergency department whose x-rays were negative, ages 5 to 12, and the clinician, the ED doctor, or whoever was seeing them in the emergency department, so ED is emergency department, sorry, emergency room. So whoever was seeing them thought, based on their exam, well, their x-rays are negative, but where I'm pushing, they hurt, this kid's got a Salter-Harris 1 fracture of their distal fibula. They've got a growth plate fracture. So they did MRIs on all of these kids. And out of 135 kids, they only found that 4 of them actually had a Salter-Harris 1 fracture of their distal fibula. And 2 of those were only partial injuries. But all 4 of them still had some ligamentous injury and had some sprain in through there and involved the ATFL, or the anterior talofibular ligament, through there. 108 or 80% of those kids that they thought had a Salter-Harris fracture actually had a ligament injury. They had an ankle sprain, okay? And 38 of those also had a little fibular avulsion fracture where the ligament attaches. They kind of pulled off the attachment to the ligament and through there that they couldn't see on the x-ray. And 1 in 5 only had a bone contusion and didn't actually have a fracture in through there. So I think that there's been several studies that have been similar to this that may kind of reshape our thinking and our traditional teaching of, when I was in training, it was always taught, it's like young kids don't sprain their ankles, they break them. And we definitely want to think about that, but they're not always a growth plate fracture. And I think young kids certainly do sprain their ankles as well. This is sort of what I was talking about. This one is maybe an avulsion fracture that you can see, but we think that there are some that are cartilaginous that you can't see, because especially in younger kids, this bone and the epiphysis of the lateral malleolus has not fully formed into bone or ossified yet, so there's a big cartilage component to it, and so they may pull off a piece of cartilage that we can't see on the x-ray initially, but this one you can sort of see a little bit. And so the question is, does this turn into this, or is this just an extra little bone? People get what we call an accessory bone or an os subfibulaire, and so is that really kind of the sequelae of this, and the years later does it turn into that, or is this a separate issue in through there? So there's been a couple studies. I'll highlight one here. We do see those little extra bones by the fibula in about 1% of people, and so this one looked at 37 patients who had a fracture that they knew about, and they followed them at least for 6 months, and they found that about 40% of them went on to form that little extra bone. And so this is following the same patient, and so this is the initial x-ray. You can't really see much there. And then at 4 months, you could see something. And then at 11 months, you could see something. And two years later, you can see that well-rounded little piece of bone in through there. And so I think a lot of times we'll see these patients in clinic, and they're doing just fine. And they've got that little bone in through there. And you kind of ask them, like, hey, did she ever have an ankle injury? Oh, yeah, when she was younger, she may have rolled her ankle. We didn't think much of it, and she did fine. And so, they're not always problematic, but we do think that may be how some of these form. So that is a common injury there as well. So how do we treat these, the Salter-Harris ones? Well, is it PRICEMMS? We talked about that. I think, treating their pain. Is it a boot? Is it casting? Is it bracing? Do we rehab them? And if so, is it a home program? Is it physical therapy? Is it working with an athletic trainer? A lot of these younger kids may not have ATs. And then we want to progressively return them to sport. And so we probably do a combination of all of these. This was a study done by some of our colleagues here, Dr. Ellis and his team, and looking at, they did a survey looking at what's POSNA, which is the Pediatric Orthopedic Society of North America. They did a survey looking at over 200 POSNA members that are fairly prominent, usually pediatric orthopedists across the country, and asking, how do they manage these? And the most commonly, people would put these ankle injuries into a boot. About a third would recommend physical therapy or a home rehab program if they had an ankle sprain, but only about 10% would recommend it if they had a Salter-Harris 1 fracture. Of the kids that were cast, or of those who used casting for the Salter-Harris 1 fractures, about 10% had cast complications. So it helps us sort of reframe is, do we need to be putting these kids with suspected Salter-Harris 1 fractures in a cast when I just told you that they probably don't have a Salter-Harris 1 fracture based on previous studies, right? They probably have an ankle sprain. If 1 in 10 of them are gonna have complications, that may not be the best. So maybe early mobilization, protect them, treating them based on their pain and progressing them is gonna be better for these kids. But I think their outcome was essentially that we found a lot of variability. And part of this is, again, despite the commonality of these injuries and despite how long we've been treating these, the evidence is lacking. There's not a lot of great evidence on how to best manage these. And so we're continuing to try to study these. We're continuing to try to look. And they did another review and looked at that and found that there's a lot of variation in what's best for this. So move on to our next case. This is now a 14-year-old who presented with an external rotation injury during a football game last night. So I intentionally kind of talked to you about that a few minutes ago about high ankle sprains. So that may be in your mind here. This kid was sent home. They said the x-rays looked negative. Went and saw the pediatrician the next day, and the pediatrician said, this ankle is really swollen. This one's concerning me. I know the x-rays were normal, but I'd like you to go see the sports medicine team. And this kid's really swollen, not able to put any weight on it, and it's hurting kind of over the anterior tibia and kind of over the lateral ankle. So you're thinking, okay, well maybe that high ankle sprain is still in play and through there. But again, as I told you, I want you to think about, growth plates first in these kids. And so he's 14. So ossification occurs in a predictable fashion. We kind of know, how the ankle will form. And so with these, we often will get what we call transitional fractures. So I want you to just be aware of this concept of transitional fractures. These occur when the growth plate is transitioning from being open and growing to being closed and being sort of an adult bone and through there. And because of the way that it closes in a variable fashion, then it's susceptible to unique injury patterns and fracture patterns, which we call transitional fractures, and there's a couple of those. So it typically starts to close, and then it starts to close out medially, then it will close laterally. And that takes a little bit of time, and so we'll see in these adolescent kids these two different types of fractures. One is known as a triplane fracture, and one is known as a Tillot fracture. So the triplane is really, it's a three-part, it involves three planes. It sort of comes through this way, it comes through here, and it comes through there. And so we'll show you some imaging of that in a second. But it's kind of into three parts. So it's sort of a combination of a Salter-Harris 2 coming through here and a Salter-Harris 3, and it comes through the growth plate there. And so this is a little bit younger in terms of their closure pattern that we'll see than the Tillot fractures. But realistically, if you don't manage these, probably any of these, even I'm probably in consulting with my orthopedic colleagues on how to manage these fractures at best, because again, this is potentially a devastating injury, and we want to make sure that growth plate, as well as we preserve the growth plate as best we can, we preserve the stability of the ankle, and we preserve the congruity of the joint surface. We keep that joint surface healthy there. And then the Tillot fractures are a Salter-Harris 3, and these may be missed, but you can kind of see a little lucency kind of coming up in through there, and that's because the AITFL is still holding on, and it kind of comes up. And again, same thing. So here's, get those three views. You may be able to see it a little bit better on different views. Here is showing maybe a CT, kind of showing us that Tillot fracture coming through, and this is after one of my colleagues treated it. Now that gap is closed, they got a screw in there, that's gonna heal real nicely, but if this goes unrecognized, you can imagine how that may not be good for the long-term health. Here is showing you a triplane fracture from the sides, kind of coming up here and here, and this is showing that same fracture kind of from the top. It's split into 3 pieces in there. Again, same concept. We want to get this reduced and back to normal. So moving on, we're getting close towards the end here. Our last case is a 14-year-old female. Reports that she landed short during a tumbling pass on the floor and felt a pop in her ankle associated with pain. She has a lot of pain over the Achilles tendon, can't really walk on it, and she has a positive Thompson test. A Thompson test is where we have them lay prone and we squeeze on their calf, and their foot should plantar flex because of the Achilles tendon there, and if the Achilles tendon is ruptured, when we squeeze on the calf, the foot doesn't move, and a lot of times you'll see a difference because there's a little bit of plantar flexion because of the tension of the Achilles, and so one foot may be kind of hanging down straight and the other one's got a little bit of plantar flexion there. So here, this is a less common injury, certainly very common injury in adults, but less common in adolescents than adults. And so if you have suspicion for an Achilles tendon tear, partial tear, or rupture, complete rupture, we do want to get imaging. And so an MRI, here's an MRI showing a nice, not for the patient nice, but very nice view of the Achilles that's completely ruptured through there. And this is showing in that same patient the ultrasound showing here that complete tear. And so most of the time, now in adults, a lot of the times these may be treated non-surgically, but it seems to be that surgical treatment is preferred in younger athletes, especially, again, in our athletes, and we want to get them in soon. So if you see this, get this over to the surgeon, the sports surgeon, sooner than later so that they can at least have the option of providing a surgical repair. So we'll close by talking about some prevention of these injuries. There's been some good studies looking at ankle bracing, so we'll go through just a couple of these here. This one looked at about 1,000 high school volleyball players, 60% of them were female. They were randomly assigned one of these 5 braces you see on the right, and there's quite a bit of variability in them. But they found that overall using braces didn't significantly decrease the incidence or change the incidence of ankle sprains in those volleyball players. But it helped a little bit in some of those who had previous ankle injuries to maybe not have a recurrent injury, especially some of these more rigid ones there. And so he said, well, that was kind of some limited evidence. Maybe it's a good study, but maybe not a lot of evidence to support bracing. Things have changed a little bit. So we move forward. The next year, Tim McGuinn and his group up at Wisconsin, they worked with their high school athletic trainers and all the schools they cover. And they did a great study where they randomized athletes to both high school basketball players and high school football players to bracing or no bracing. And they followed them, and they had athletic trainers follow them, and they made sure that the athletes were wearing the brace, and they kept track of the injuries. And there were thousands of athletes in each of these studies. So really high, well-powered studies. And both of them found a significant decrease in the incidence, meaning the occurrence of ankle sprains in the group that was braced. Okay? When they did get hurt, they were about the same in terms of how long they were out. It's about a week. They got back, most of these, fairly mild. But in the basketball players, it was about a third. So 1/3 the risk of injury in those who had bracing versus those who didn't, and about half in the football players. So pretty significant reduction in the risk of ankle sprains, at least in this group that wore braces. And these are just the standard sort of lace-up ankle braces that they wore. They did not see an increase in knee injuries or severity of knee injuries. And so that's one of the concerns a lot of people worry about is if you're going to wear an ankle brace, well, it may protect the ankle, but is that force going to move up and injure the knee? And at least in this study, in the football players, they didn't see increased knee injuries or severity in through there. And so some good evidence that perhaps ankle bracing may be used to help reduce the risk of ankle sprains, at least in high school basketball and football players. Need to do studies in other sports, but these were kind of essentially what they used. We talk about sort of that lace-up ankle brace there, or what we call the figure-of-8 ankle brace. So this was a systematic review. We say to brace or not to brace. It was a big question. And they, their title of their study, I guess, tells you what they felt like their outcome was. Ankle bracing is effective for primary and secondary prevention, so preventing an ankle sprain and then preventing recurrence of an injury in athletes. And they did a systematic review, and I think they had 6 studies, including the 3 that I showed you before. They said ankle bracing is effective. Athletes without a previous ankle injury who wear ankle braces have about a 50% reduction in the risk of ankle injury. Athletes with a previous ankle injury have about 60% reduction in the risk of acute ankle injury. And so they said their conclusion was those playing court and field sports maybe should consider wearing an ankle brace during training or games to reduce the incidence of acute ankle injuries. And then there was another systematic review, and again, sort of same concept. They said athletes who wore braces had fewer ankle sprains and reduced their risk of sprains by about 64%. The other thing that we found was athletes performing balance training. They looked at all the studies. So this is showing you those studies down here and kind of the relative risk. So here is basically, there's no effect. And when it falls on this side here, especially if it doesn't cross over, it means that it reduces the risk of an injury. So this is showing all those studies that they did, and based on 3,600 subjects across those 6 studies, they found that balance training prior to the season or as part of their training also helped reduce the risk of injury. So some good evidence perhaps for bracing and balance training that at least most of the studies show a positive effect, some of them sort of neutral. So as we know, foot and ankle injuries are very common, and even though we kind of maybe dispelled the myth of the super common Salter-Harris 1 fracture, distal fibula, we still want to think about fractures, whether it's our transitional fractures, avulsion fractures, osteochondral fractures, again, those Salter-Harris fractures, a fracture, and getting x-rays following clinical decision rules if we want to, and then maybe consider bracing and balance training for the prevention of ankle injuries in some selected populations. So. Thank you for your attention, and I think we have a few minutes for discussion and question and answers.
Okay. They told me to stand over here, so sorry if it's awkward, Dr. Miller. That's how that media people told me to stand over here.
I feel like it's May of 2020. We're just social distancing.
That's right. Well, that's why I'm going to stand over here for any Q&As.
I feel more comfortable.
I think one of the things that has always been so impressive to me is how often we all see ankle sprains. It's got to be one of the most common sports-related injuries that we see, and the variability in the treatment that we probably see. And I think you alluded to that a little bit. So do you guys have any questions in the audience before I ask my questions? Anybody?
So these lateral ankle injuries, primarily where I'm at in the fracture clinic here, I see a lot of our younger kids that come in with these. And the question we always get is, we kind of explain to them once it happens once, you're more likely to have these ankle injuries. I think that's a little bit, more for our adolescent population. I think that's probably more applicable. I think part of my question is for you guys, how y'all address that question of how do you prevent these or best way to prevent them in the future. But more importantly, I'd like to know from the audience and our therapists out there, what y'all's approach to managing the younger population. Because as you guys all know, where we live, all these kids are the next stud, right? They're all elite athletes. And so the 7-year-old parent always has the question of, well, can I do therapy? We need therapy. And you're kind of like, well, they're 7 and you can do this at home with some of these. And do you guys as therapists find the value in the kids at that age when they come in? Are y'all able to get an effective program that really assists or helps them? So I guess we'll start with any of the therapists out here that might want to address that. Any takers? Perfect.
Yeah, I mean, I think a lot of it is educating mostly the parents. The kids, they'll do what the parents say. So if the parents are on board and they know kind of what exercises are need to do, I think even one visit, you can just say, here's a home exercise program, get them set up that way. Really show them like the importance of it and kind of how they need to rest before they go into their sport. So mainly it's just about educating the patients, but not that they have to come in. But a lot of times with my kids, it's like, if you can make it a game, they'll be so much more bought in versus like do 30 ankle plantar flexion with a band. It's like, okay, let's make it a game and they'll be way more bought in to do it. So that's kind of my suggestion for those kids.
Yeah, I love the concept of making it fun. I think that's so important, especially with the younger kids, is whether it's sport participation in general or like you said, the treatment plan. I think that's a great concept. And I think it's individualized. I don't think that that's universal because, if you take your sort of normal quote, 7-year-old who's going to go back to, second grade and go back to PE and recess, most of them are going to do pretty well after a lateral ankle injury without much intervention. Whether we brace them or we don't, or we give them home programs or not, they're going to do pretty well. The risk of complications is pretty low. But like you said, now you've modified that, right? You've taken a 7-year-old who's now playing 7 baseball games a weekend, or 7 soccer games a weekend, and training throughout the week. That's not the same, even though the injury may be the same. It's just not the same child, and so I think that their exposure risk goes up. That what they're asking them to do goes up, and so that kid may benefit from more of those than sort of the typical child. And then I think the opposite is true. Some of our kids with more pain tendencies, the ones that are not going to move it on their own. The kid that kind of bounces back and's run around the clinic room and looks pretty good, they're probably going to be fine. But the kid that won't walk on it or won't move or is walking around with the pirate leg and doesn't want to do things, I think those also could really benefit from some intervention to help kind of keep us off of that pathway from getting down the road. And so I think that there's probably both ends of that bell curve. Definitely would benefit. And then the ones in the middle, again, still try to addressing some of that. And then the question of, what do you do about, is it home versus outpatient therapy? I think depends on the child as well.
And that second kid you talk of, the 7 baseball games, are you bracing that kid? You putting that kid in a brace? Because I traditionally have not, and I don't find a brace that I've found a lot of success in that size either.
Yeah, I think that we don't have any evidence in that age group right now, right? The studies that we talked about are looking at high school athletes in very specific sports. And so, if you take that population, perhaps that's a good recommendation to say, hey, look, there's evidence that probably this can help reduce the risk of recurrent injuries, bracing and or taping. And I didn't talk much about taping. Taping feels good. If it's done correctly, the athletic trainers are very, very skilled in that. Some physical therapists are skilled in that as well. It tends to loosen up, and it's hard to get it done right. And so when the family's taping it themselves or they're just trying to get through it, I think that an adjustable lace-up ankle brace is probably going to be as good, and they can put it on and off. But I think that we need more data before we can really make good decisions or recommendations in that younger population under 10.
Just to answer that question a little bit more, something that Dr. Miller taught me about 10 years ago that we identified when we did that systematic review is that balance training was probably the most effective at prevention. And so I heard Dr. Miller 10 years ago talk to his patients about balance training and a few tips to do that at home. And so that was the only thing we found in the literature that had suggested any prevention strategies. So it was a lesson he taught me that we further supported by the literature. So that's usually my biggest message for ankle injuries. One of the questions that we're running a little bit short on time, so I'm going to conclude with this question. But we can always walk the walk and talk the talk, and let's sleep 8 hours every night. Let's eat 3 healthy, well-balanced meals every day. But the reality of what is the right thing to do and that what actually happens is a very tough distinction. And so we all are dealing with a lot of high-level athletes where maybe perhaps sometimes we just want to tape that ankle up and get back into the game. And so my question for you is that a big problem? Is that okay to do? I realize that may not be the right thing to do on paper or textbook or when we're up on the podium, but it probably is what happens in reality a lot. Let's just slap a brace, let's tape it on and get them back into the game. How much of a problem is that for us?
Yeah, so since I'm on the podium, I'll have to give the podium answer. But no, one of the concepts I teach our residents and our trainees, I say there's a big difference between sideline medicine and clinic-based medicine. How I may manage that ankle injury at the time of the injury on the sidelines may be very different. And some of that's the actual injury. By the time they come see us, they're more swollen. They may be able to continue to play with, a brace or a tape and be able to finish a tournament. But then, we see them a couple days later and they're really struggling. So then I start to fall back on, that clinical decision rule is, they don't have to be 100% for me, right? This is not, again, I see a lot of concussions, so I explain to them, like maybe this is not a brain injury where your risk is there, and we have to weigh the risks and the benefits. And if this is a super important tournament, and we think that you can play relatively safely without increasing, your risk of obviously worsening the current injury or ACL injury, or something else, and you can function at a high level and actually help yourself and your team, then I think that it's not an unreasonable thing. So we have those conversations frequently with the family, and we individualize it based on all of those other factors that we kind of went through. And you're right, we may not come to the same conclusion for the exact same injury in two different athletes within the same clinic day.
Yeah, I mean, I think that's a great answer to that question. You know, assess the individualize the treatment and then a shared decision-making model, including the parents and the family. And that really goes into the importance of our next talk, which is uncommon injuries, because I think that many times we use a textbook and a reference for return to play guidelines and what do we do with this athlete and that. The reality is it probably depends on what sport they play and how aggressive and competitive they are. And so individualizing treatment sometimes is the best thing for us to consider when we're treating these youth athletes. So I would encourage you guys to either join us online, and thank you guys for the online the viewership online, as well as you guys who came here today. We'll be here next month talking about uncommon sports injuries with Dr. Jones. So I appreciate it, and we'll be around a little bit more if you guys have any further questions. Thank you.